During the COVID-19 pandemic, the world watched a virus cross international borders without friction. Yet, a person's chance of surviving that infection was strictly divided by their geography and their wealth. To understand why this massive health gap exists today, we have to look at the 4,000-year evolution of public health, as documented in Chapter 2 of Dr. Biennilo's textbook on community medicine. Early human societies believed illness was a direct punishment from the gods, or the work of vengeful spirits. Because they viewed the cause as entirely spiritual, they left healthcare exclusively to priests and shamans. But as human settlements swelled into massive, densely packed ancient cities, spiritual remedies could no longer manage the sheer volume of waste and disease. Keeping large populations alive required a pivot to physical logistics. Public health began with the brutal math of urban density and sanitation. The Roman aqueducts stand as early proof of this, engineering clean water delivery and massive sewer systems purely out of civic necessity. By the 1800s, the Industrial Revolution was driving enormous economic growth. It also crammed workers into incredibly filthy, polluted urban centers. At the time, the leading medical consensus was the miasma theory, the belief that breathing foul odors directly caused diseases. Social reformers like Sir Edwin Chadwick pushed for massive garbage removal and sewer projects, specifically to clear the air of these bad smells. Meanwhile, in Paris, a physician named Louis-René Villermé tried to figure out why specific districts had much higher death rates. He tested proximity to the river, prevailing winds, and soil types, but none of those geographic factors matched the mortality data. This chart visualizes Villermé's findings, mapping mortality rates in Paris directly against local tax brackets. Influenced by utilitarianism, the economic philosophy of measuring human misery to improve state efficiency, Villermé discovered that death correlated strictly with poverty, rather than wind patterns or geography. By mapping this data, early researchers proved that disease functioned as a measurable socioeconomic symptom, distinct from physical environmental hazards. Moving into the late 19th century, the scientific understanding of illness finally caught up. Germ theory gave researchers an exact biological target to hunt. Scientists like Louis Pasteur definitively proved that microscopic organisms, rather than foul odors, were transmitting infections from person to person. This new biological certainty merged with growing state power. In Europe, thinkers like Johann Peter Frank argued for a medical police, a system where central governments actively monitored vital statistics and enforced hygiene, sanitation, and school health. As European powers expanded their empires, they exported these centralized health strategies globally, utilizing top-down medical interventions as tools for colonial administration and population control. In the Philippines, this began in the 1500s, when the Spanish crown established medical control through religious dispensaries and monastic hospitals to serve local populations. Later, during the American occupation, the colonial government deployed highly specialized top-down interventions to aggressively stamp out epidemics of cholera and smallpox. Entering the 20th century, public health possessed a high degree of biological accuracy, yet it largely operated as a rigid system of state control, rather than a collaborative effort with the communities it treated. In the decades following World War II, the world mass-produced vaccines and antibiotics, yet the life expectancy gap between wealthy nations and low-income, fragile states continued to widen. Recognizing this failure, global health leaders met in 1978 to draft the Alma-Ata Declaration. The document formally rejected the strict biomedical model, which treated the human body like a machine, and healthcare as something delivered only by specialists in high-tech hospitals. The Declaration redefined health as a human right and a worldwide social goal, requiring complete physical, social, and mental well-being, rather than the mere absence of pathology. This flowchart maps the core concept born from that summit: primary healthcare. It shifts focus from reactive hospital treatments toward organized communities and an enabling environment. To achieve lasting public health outcomes, practitioners must address the root causes of illness. In this framework, the practitioner steps out of the isolated exam room. In community medicine, the collective social body becomes the patient. 4,000 years of medical history point to one conclusion: empower a community to build its own health produces the most durable medical outcomes.